All right, thank you guys for joining me. I don't know about you, but I've been I've been pretty bored these last few weeks. Not because there's a significant lack of things to do, because there certainly is, um, but they are logistics and planning and scheduling and strategizing, and not necessarily the things that I enjoy doing or that we love doing as practitioners and as students and as instructors. Um, so there's been a lack of that. My numbers are down in my clinic. We're not teaching any courses right now, and so therefore I've lost the opportunity to teach and learn from all of the instructors at the Jones Institute, and then missing my patients too. So I'm sure a lot of you guys are in the same boat. I do want you guys to know that we are working. We're working for to handle all of your inquiries and requests. Um, we are we're strategizing for when the economy opens back up, that we can offer you guys economical options for how to continue your Counterstrain education, whether that's through an online format or videos or hybrid models that we're working on right now, and figuring how to put all that together. So in the meantime, what I thought that I would do is put together this anatomy webinar. And what we'll discuss today is the cranial anatomy. Not all of it, but a significant portion of it, specifically with how it relates to the cranial nerves. And then we will jump down into the cranium, into the infratemporal fossa, and discuss the neurovascular structures that run through that and the impact that they can have on our patient caseload. I do have another anatomy webinar that I'm working on that's going to do a deeper dive into all of the cranial anatomy, which is going to be really designed to help prepare people who aren't as up to date or as prepared for the central sensitization courses from an anatomical standpoint, or even a palpatory anatomy standpoint. So I'll be working on that as well, and that'll be another webinar that will figure out how to get it to you guys. And then Brian Tuckey has also prepared a webinar on scar tissue. So that's in production and in editing, and as soon as that's ready, we'll get that out to you guys too, just to help keep you engaged and learning some new stuff during this time where it's hard. It's hard to stay engaged with the techniques and the courses that you guys love. So hopefully all of you are doing well, and your numbers haven't been reduced too much, and maybe there's patients that you're currently stuck on. Maybe you've run out of techniques and aren't sure what to try next. So our hope is that by reviewing the anatomy, or maybe even learning anatomy for the first time, maybe not for the first time, but learning new anatomy, and the nitty gritty and the specifics and the detail, instead of just kind of the global muscles, origins, insertions, actions, and innervations, and then learning about scar tissue and how we can release that with Counterstrain and how impactful that can be in the body. That it'll give you some new tools to work on with your patient caseload until we can get our courses up and going again. So let's start the webinar on cranial anatomy and the infratemporal fossa. So the clinical relevance of this region of the body is going to be for your patients with TMJ pain, with dysphagia, difficulty swallowing, with dysarthria, difficulty speaking because the muscles that control speaking get weak, facial palsy, trigeminal neuralgia, facial paresthesia, so any numbness, tingling in the face, tongue paresthesia even, which is actually a patient that I've had, a patient that complained of her chin being numb and her tongue being numb. And she had seen multiple doctors and had all tests run, because numb chin is actually a red flag for some sort of sinister pathology. And all her tests came back negative, and her doctors ended up prescribing her antidepressants and telling her that it was likely all in her head. And kind of sent her on her way. So that was the patient that I had that I worked on, and we worked on the infratemporal fossa and all the anatomy within it, and helped her quite a bit. Impaired taste can be another sign or symptom of dysfunction in this area, and then patients with digestive issues. So, we treat the viscera, we treat the valves, we treat the sympathetic and parasympathetic nervous system, but digestion does start in the mouth with the secretion of saliva. So your submandibular glands that are deep to the mandible, your parotid gland that's a more superficial gland outside of the masseter, all important structures in regards to their function with digestion. And then more globally, cervical pain and headaches. These little tiny structures that have very specific functions within digestion and taste and sensation, they also have, they can have a big impact on neck pain and headaches too, chronic headaches. So those are the types of patients that you probably have in your clinic that this specific region of the body would relate to. So bony prominences that are relevant to the infratemporal fossa, we're going to have landmarks that are attachment points of muscles, the deep muscles of the infratemporal fossa, like the pterygoids, and then we're going to have bony prominences that more superficial muscles like the masseter and the temporalis attached to, and then foramen and grooves that neurovascular structures run through. So if we look at this PA view of the cranium here, the first landmark to identify is the tuberosity of the maxilla, which is one of the attachment points for the medial pterygoid. Up here we have the sphenoid. Let me get my laser pointer out here. So here's that tuberosity of the maxilla here. Up here we have the sphenoid bone and the medial pterygoid plate and the lateral pterygoid plate. And the lateral pterygoid plate is going to have a medial surface, which you can identify here, and then on the flip side of that is the lateral surface of the lateral pterygoid plate, and they are attachment points for the medial pterygoid here, and then the lateral pterygoid on the lateral aspect of the lateral pterygoid plate on the other side. Coming over to the mandible, we have the head of the mandible with the pterygoid fossa, which is an attachment point for the lateral pterygoid. This little mandibular notch here, which ascends up into the coronoid process, which is the attachment for the temporalis muscle. This bony surface here is the ramus of the mandible, and on the medial aspect of the ramus of the mandible, there is a mandibular foramen here, leading into a mandibular groove where we have some neurovascular structures running through that we'll identify later in the next couple of slides. The ramus continues inferiorly, and there's an angle of the mandible here before the mandible turns anteriorly and turns into the body of the mandible. So this angle of the mandible is one of the attachment points for the medial pterygoid as well. If we look at the inferior surface of the cranium, then you'll see a lot of holes in foramen where neurovascular structures are entering and exiting the cranium. So the ones that we'll talk about today, we'll actually talk about all of them in the next slide pertaining to the cranial nerves, but the ones that we'll talk about here are specifically the ones that are relevant for the infratemporal fossa. So the middle meningeal artery, which is an artery that comes off of the maxillary, going through the infratemporal fossa and up through the foramen spinosum. So your foramen spinosum is this round circular foramen right here. So again, the middle meningeal artery travels through there, and that has actually blood flow or blood supply to the dura. The stylomastoid foramen, which is just behind the styloid process. It's a little tough to see in this picture, but here's your styloid process right here, and just behind that is your stylomastoid foramen, which is the exit point for your facial nerve. And so facial nerve comes off of the brain, exits the head through the internal auditory meatus, and then exits the exterior of the head through the stylomastoid foramen. Then we have your carotid canal, which, let's see, is here. right there, your carotid canal. That is the canal that your internal carotid artery enters the cranium through, and that's major blood supply to the circle of Willis. And we don't necessarily see the internal carotid artery in the infratemporal fossa, but we do see the branches of the external carotid. So just to give you guys a full picture of both internal and external carotids and what kind of happens to them as they terminate or as they flow into different structures. And then the big foramen for the infratemporal fossa is the foramen ovale, where the mandibular branch of the trigeminal nerve exits the cranium, and that is going to be right here. So just anterior to the foramen spinosum, which was here, a nice oval-shaped foramen where that V3 trigeminal branch exits the cranium. If we take a look at the superior to inferior view of the inside of the head, then we can identify three different fossas. So we have the anterior fossa here, the middle fossa here, and the posterior fossa here. And this is where we'll run through the fossas anterior to posterior and identify all of the different foramen and the cranial nerves and some of the vascular structures that run through them. So in the anterior fossa, you have the cribriform plate here. This is where our olfactory nerve lies, so the olfactory bulb lying right over that cribriform plate. That's your smell, your special sense smell nerve. Just posterior to that, tucked into the sphenoid, is your optic canal. So this is the foramen that your optic nerve runs through. And then also a small ophthalmic artery, which comes off of the internal carotid artery, also runs through that canal going to the eye. There's a ridge right here between the anterior fossa and the middle fossa. And if you fall right off of that ridge, there's a big fissure there. It's your superior orbital fissure. And there's a lot of structures that run through there. There's your oculomotor nerve. So motor innervation to a lot of the muscles of the eye. Your trochlear nerve runs through there. Motor innervation to the superior oblique muscle. The trigeminal V1 ophthalmic branch also runs through there. And then your abducens nerve, so motor innervation to the lateral rectus, also runs through that superior orbital fissure. Just behind the superior orbital fissure is your foramen rotundum. That is the foramen where the trigeminal V2 maxillary branch runs through. Come a little bit posteriorly, and there's that foramen ovale again. So again, the V3 mandibular branch of the trigeminal nerve exiting the cranium through there and entering right into the infratemporal fossa. Behind that is the foramen spinosum with the middle meningeal artery. And then we have separating the middle fossa and the posterior fossa is this protrusal ridge. If you fall off of the protrusal ridge, there is the internal auditory meatus or internal acoustic meatus. And again, the facial nerve exits the cranium through there and then externally exits the cranium through that stylomastoid foramen. The other nerve that exits through the internal auditory meatus is the vestibulocochlear nerve going to the inner ear. Inferior and kind of posterior to that is the big jugular foramen, and you can see the transverse sinus here, the groove for the transverse sinus, dumping down into the groove for the sigmoid sinus, and then exiting through that jugular foramen into the internal jugular vein. Other structures running through there are the glossopharyngeal nerve, the vagus nerve, and the spinal accessory nerve. And then lastly, going down into the foramen magnum, there's a small canal, your hypoglossal canal, where your cranial nerve 12, hypoglossal nerve, exits the cranium. And then the big foramen magnum, where our spinal cord, our meninges, our vertebral artery, so two vertebral arteries that come up, form the basilar, and then contribute to the circle of Willis as well. And then the spinal accessory nerve is mentioned here as well because it comes up through the foramen magnum and then exits the head through the jugular foramen to go to the sternocleidomastoid and the upper trapezius, right? So it's motor innervation to those two muscles. So for the muscles of the infratemporal fossa, the two that we're going to discuss in detail today are the lateral pterygoid and the medial pterygoid. But before we do that, if we look at this lateral view of the cranium, you can see the lateral pterygoid muscle here and the medial pterygoid muscle here. But in order for us to have a sense of what depth we are in the body, it's important to kind of layer back on some of the structures that were taken off in this picture. And this picture is actually a perfect picture for a point within the dissection that we try and get to, where the zygomatic arch is removed and the ramus of the mandible is removed so that we can really see into the infratemporal fossa. In the dissection, we do try and keep a little bit more of the body of the mandible on here so that we don't destroy the mandibular foramen and the mylohyoid groove, so we can really identify the neurovascular structures running through there. The other structures that were taken off in this picture are obviously all the facial muscles, and then the temporalis muscle, which would originate here in the temporal fossa and attach to the coronoid process. More superficially here, the mastoid, the masseter, was removed. Its two heads, superficial and deep. The parotid gland was removed. The parotid duct was removed. The facial nerve was removed, and we'll talk about the facial nerve a little bit here on the next slide. So all of those things were taken off in order for us to get to this viewpoint here. So to discuss these muscles, the lateral pterygoid, again, this muscle here in the top picture, and then this muscle here in the bottom picture, the posterior view. It's going to originate from the infratemporal surface and crest of the greater ring of the sphenoid and the lateral surface of the lateral pterygoid plate. So we discussed that lateral pterygoid plate. It has a lateral surface and a medial surface. Lateral surface is where the lateral pterygoid originates from. The medial surface is where the medial pterygoid originates from. The lateral pterygoid is going to insert into the TMJ capsule and disc here, and that pterygoid fovea that we mentioned when we were going over the bony landmarks. And then it's going to be innervated by the mandibular branch of the trigeminal nerve. So we think of the trigeminal nerve as sensation, right? Sensation to the face, but it carries motor fibers to the pterygoid muscles and some of the other muscles that we'll discuss in the next few slides here. And then we'll learn a little bit later on the other types of fibers that it carries through its nerves as well. So the action of the lateral pterygoid is contralateral deviation, protraction, and depression of the mandible. So contralateral deviation, if my right lateral pterygoid contracts, my mandible is going to deviate to the left, right? The medial pterygoid is, again, this muscle here on the top picture and this muscle here in the bottom picture. It originates from the medial surface of the lateral pterygoid plate. So here's that lateral pterygoid plate here. Here's the medial surface of it, where you can see the medial pterygoid originating from. And then on the flip side, if that's the lateral pterygoid plate, then there is the lateral surface of it, where the lateral pterygoid is originating from, right? So medial pterygoid originated from the medial surface of the lateral pterygoid plate, the pyramidal process of the palatine bone, which is a structure here, and then the tuberosity of the maxilla, which it would be kind of deep to the medial pterygoid here. Same innervation, mandibular branch, V3, trigeminal nerve. And then in addition to being a contralateral deviator, this muscle is also going to be more of an elevator and a protractor of the jaw. So going backwards in the dissection, more superficially, we have the facial nerve. So in order to get to the infratemporal fossa, we do have to reflect or cut away the facial nerve. Here you can see the styloid process, and just behind that, the stylomastoid foramen, where that facial nerve exits the cranium. And then it's going to have 5 major branches. The temporal branch coming up here, the zygomatic branch going towards the zygoma, the buccal branch going towards the cheek, the mandibular branch following that angle of the mandible, and then the cervical branch coming down into kind of the area of the platysma. So again, this is actually one of the more interesting nerves to see in dissection, because these nerves are so small. Yes, they do have these 5 branches, but they have so many other branches that are just splaying out towards all the areas of the face providing the motor innervation for all the facial muscles. So real thin, real easy to reflect, but hard to keep it all intact because there's so many little branches of it. But for the sake of this dissection, what we can do is cut the nerves here at the terminal ends of all of those 5 branches and then just reflect it backwards towards that stylomastoid foramen. So mixed in with the facial nerve are the superficial arteries of the face. A lot of those branches come off of the external carotid artery. So here you can see the top end of the external carotid artery. And at this point, it's already given off a couple of branches, some of which you guys know if you've taken the arterial class. The superior thyroid artery, so coming off the external carotid and running inferiorly to the thyroid gland. Another branch coming off the external carotid is the lingual, and the occipital branch coming backwards here into the suboccipital triangle. And then coming anteriorly and superficially across the face, so kind of the superficial aspect of the infratemporal fossa, is the facial artery. And to help us identify the facial artery, you can find a couple of branches of it, either the superior labial artery here coming to the top of the lip, or the inferior labial artery here coming to the bottom of the lip, and then we can trace those backwards to pick out the facial artery. And then after giving off those 2 branches, the facial artery is going to continue and change names to the angular artery as it heads up towards the bridge of the nose. From the superficial view, you can also see that parotid gland here with the parotid duct. And then as the external carotid artery continues, you do see a transverse facial artery here. But then it's going to branch off into 2 main branches. And the one that you can continue to see is the superficial temporal branch coming up into the temporal fossa. The one that you can't see from the superficial view is the maxillary artery. So a really important artery that has various branches that come off of it as well, which we'll discuss here in a second. And that's going to be deep to the masseter, deep to the pterygoids. So we have to do some dissecting in order to get there. So here is that maxillary artery and its branches. You can see it coming off of the external carotid artery here, taking that hard anterior turn going into the infratemporal fossa. It's going to give off various branches, some deep temporal branches here, a couple of muscular branches going to the masseter and the pterygoids, a buccal branch here going to the region of the tongue, an inferior alveolar branch, which actually continues down, goes through that mandibular canal. It's going to give off some blood flow to the mylohyoid muscle, and then that inferior alveolar artery continues and exits through the mental foramen as the mental artery. The maxillary artery then continues and goes through the infraorbital fissure, and actually has a branch that comes out through the infraorbital foramen here as the infraorbital artery. But the coolest artery, and probably the most clinically relevant artery that the maxillary gives off, is the middle meningeal artery. So that artery comes off the superior aspect of the maxillary and heads up through the foramen spinosum and supplies blood to the dura, to the facial nerve nuclei, and to the periosteal tissue of the cranium. And pretty cool, on the inside of the cranium, in the cranial fossa, you can actually see the groove for the middle meningeal artery and its branches kind of implanted into the inner side of the calvaria. This artery here that you see kind of next to the middle meningeal is called your accessory middle meningeal artery. It's also blood flow to the dura, but instead of going through the foramen spinosum, it actually goes through the foramen ovale, which is the same foramen that the V3 mandibular branch of the trigeminal nerve exits from. But so slight variation. Some cadavers have that accessory middle meningeal, some don't. But it is just additional blood flow to the dura. So now for the trigeminal nerve, which is the coolest part of this dissection. And we'll find a lot of these structures at the same depth as we did the maxillary artery and all of its branches, because a lot of these nerves and arteries run together. So the primary purpose of the trigeminal nerve, or primary function, is sensory innervation to the face. This nerve does have the three branches that we've discussed already, the foramen that they go through, but just to review, you have the V1 ophthalmic branch going through the superior orbital fissure, the V2 maxillary branch going through the foramen rotundum. You can see here it exits as the infraorbital nerve going through the infraorbital foramen. Right, so we have a venous lymphatic sinus point right there at that foramen. And then coming inferiorly through the foramen ovale is the mandibular nerve, that V3 branch of the trigeminal, and that's the branch that we're going to look at in a little more depth here. All right, so the mandibular nerve enters the infratemporal fossa through the foramen ovale. It does give off muscular branches, right? So it does give off motor innervation or motor fibers to muscles. So the temporalis, the masseter, both pterygoid muscles are all innervated by this sensory nerve. The first branch that the mandibular nerve gives off is this auriculotemporal branch. This nerve is primarily sensory, so it provides sensory innervation to the ear, to the temporal region, and to the TMJ joint. So really important with TMJ pain is this auriculotemporal nerve. A cool thing about this nerve is that it also carries. So again, the V3 mandibular branch considered primarily sensory, but this auriculotemporal nerve also carries postganglionic parasympathetic fibers from the optic ganglia to the parotid gland from cranial nerve 9. So cranial nerve 9, the glossopharyngeal nerve, is a parasympathetic nerve, but it sends its fibers, its parasympathetic fibers, to the parotid gland to increase secretion of saliva through the auriculotemporal nerve branch of V3 mandibular nerve. So this nerve here carries both sensory and parasympathetic fibers running through it. Coming down into the foramen ovale now, we do have the inferior alveolar nerve. This nerve enters the mandibular canal through the mandibular foramen. It is going to give rise to the nerve to the mylohyoid, and this nerve innervates the mylohyoid and the interbelly of the digastric. So again, there's still motor innervation coming through this sensory nerve and innervating the mylohyoid and the interbelly of the digastric muscle. As it comes through the mandibular canal, it's going to provide sensory innervation to the mandibular teeth and then terminate as the mental nerve coming through the mental foramen and providing sensory innervation to the lower lip and chin. And you remember the inferior alveolar artery also ran through this course and exited the mental foramen as the mental artery. Right, so both mental nerve, artery, and foramen pop out of that. Nerve, artery, and vein pop out of that mental foramen right there. Another branch off of the mandibular nerve is the lingual nerve. And this is the lingual nerve right here. And this nerve is a sensory nerve. So solely sensory. And what it does is it carries sensory innervation to the anterior 2/3 of the tongue. Now the cool thing with the lingual nerve is that within the infratemporal fossa, it is joined by this nerve here, which is called the chorda tympani. And the chorda tympani comes from the facial nerve. And so facial nerve being a parasympathetic nerve as well. And the facial nerve sends both parasympathetic fibers and special sense fibers, taste, through the chorda tympani to join up with the lingual nerve, where it hitches a ride on the lingual nerve and gets its fibers carried to its effector organ. So parasympathetic fibers to the submandibular glands running through the chorda tympani, and then special sense fibers or taste fibers running through the chorda tympani to the anterior 2/3 of the tongue. So this is how we kind of break this section down for our students as far as holding them accountable for knowing this information. Is on the practical, we can tag the nerve here and ask them to identify the nerve and tell us the fibers that run through it. So if the tag is here, they would have to say, okay, that's the lingual nerve and there's sensory fibers running through it. If we tag a structure here and say identify this nerve and the fibers running through it, they would have to tell us that that's the chorda tympani, and running through that nerve there are parasympathetic fibers and special sense fibers. And then lastly, if we tag the nerve here, then they would have to tell us, well, that's the lingual nerve again, but at this point now it's carrying sensory fibers, special sense fibers, and parasympathetic fibers all running through it. So Really cool dissection. Really fun to find this chorda tympani. It's hard to find it. It's tedious. You got to pick through the pterygoids and kind of carefully dissect them out so that you can find this nerve without damaging it. But really cool dissection, and I think the concepts of parasympathetic nerves sending fibers and those fibers hitching rides on other nerves that we would consider to be primarily sensory is a really cool way that the body gets its different fibers and its different nerves where they need to go. So the last branch of the mandibular nerve is this buccal nerve here, and this one's kind of the boring one of the group. It is a sensory nerve to the cheek and travels with the buccal artery blood flow to the cheek. So just to sum up and bring all of this home, just a quick review of our 4 cranial parasympathetic nerves. We have our oculomotor nerve, our facial nerve, our glossopharyngeal nerve, and our vagus nerve. And 2 of those nerves we saw in the infratemporal fossa. So the facial nerve we saw via the chorda tympani hitching a ride on the lingual and carrying parasympathetic fibers to the submandibular and sublingual glands, and then carrying special sense fibers to the tongue for taste. And then the glossopharyngeal nerve we also saw with its fibers hitching a ride on the auriculotemporal nerve, carrying parasympathetic fibers to the parotid gland, again to help in saliva secretion for digestion. Right, so this infratemporal fossa, this B3 mandibular branch of the trigeminal nerve, which is primarily sensory, has a huge role in the parasympathetic nervous system, which is a nervous system that we treat a lot as we try to balance it out with the sympathetic, right? So that whole autonomic nervous system, we want this balance between sympathetic and parasympathetic. And who knew you had to treat the V3 mandibular branch of the trigeminal nerve in order to help balance it out? Part of wrapping this up and bringing this all together just is to emphasize the clinical relevance of this small region of the body. And here I have a large overview of all of the cranial nerves that we discussed today. So feel free to to screenshot this. I can get my little laser pen out of the way. Screenshot this if you want, just for a reference sheet. But to quickly go through this, the main nerve we looked at again was this mandibular nerve, exiting the head through the foramen ovale, carrying sensory to the skin of the lower face, and to the tongue, to the floor of the mouth, and to the lower teeth and gums. But then also carrying motor fibers to muscles of mastication, to the anterior belly of the digastric, to the mylohyoid and the tensor tympani. And keep in mind, some of these muscles attach to the hyoid bone. So this is why this nerve has an effect on cervical pain. Because if the nerve is dysfunctional, the muscles are in a state of spasm, and the hyoid bone could be pulled posteriorly and compressing some of the soft tissue behind it, or deviated to one side or the other, which could throw off the omohyoid and this cascade effect of affecting shoulder girdle placement and neck pain, and all just from the mandibular nerve. And then we also looked at the facial nerve again through that chorda tympani, carrying the special sense to the tongue, carrying the parasympathetic fibers to the submandibular and sublingual glands, and then the glossopharyngeal nerve carrying the parasympathetic fibers to the parotid gland through the auriculotemporal nerve. Right? So if you were curious as we were going through this, every structure that we talked about you can treat. We do have a counterstrain technique for. If we don't have a counterstrain technique for it, or not one that you know, then you can kind of imagine how you would decompress the infratemporal fossa using just a general position, right? So if I go to this picture here, if we wanted to decompress this whole area, you would probably use a cervical flexion, a cervical side bend, toward, rotate away, maybe a mandibular retraction and elevation up towards that foramen ovale. So if you don't know the techniques, you can try these kind of general decompressive positions to help if your patients have any symptoms that are relevant to the infratemporal fossa. But specifically, If we go to the infratemporal muscles, the lateral pterygoid and medial pterygoid, we have specific techniques for these muscles that we teach in our Jones Counterstrain Cranial course. We also have releases. We can release these muscles out in chains that are connected to the cervical spine, and we teach those in our Fascial Counterstrain MS3 course. All of the nerves that we talked about today, we have techniques for in our N1, Fascial Counterstrain N1 and N2 courses. All of the arteries that we went over today, we have in our Fascial Counterstrain Arterial course. And then, the one thing that we didn't talk too much about today, when we're doing cadaver dissections, we don't talk about them too often because veins and lymphatic vessels are hard to find. They're flimsy. They crowd the dissection field. So we end up kind of pulling them out just so we can see the arterial and neural structures. But don't forget the clinical implications and clinical significance of the venous lymphatic system in this area. So your parotid plexus, your pterygoid plexus, your internal jugular vein, all really important structures to keep in mind as well. And all of those techniques you can learn in our Fascial Counterstrain Venous and Lymphatic course. So that concludes today's webinar. I hope you guys enjoyed. I hope you learned something. I hope you learned something that will assist you in the clinical application of Counterstrain. Keep an eye out for the webinars that I mentioned in the beginning, because we're going to try and push those out to you guys as soon as we can. As soon as they're produced and edited, then we want to get them out to you guys. I really hope to see you guys soon at a course. I hope all this is behind us sooner than later, and we can meet in person again and teach each other and learn and lab and practice, because I really do miss those things. So until then, stay healthy, stay safe, and we hope to see you guys soon.